Yes, Dr. Manan.
So, may I request to share this presentation to the
Share the presentation to the
whole group? I mean, to us.
recorded version. We'll come to that. Flavia, over to you, Flavia. Just you could answer.
Yes, we have I don't know if you have access, but we have uploaded the previous seminar. It's already online. And I don't know if you have trouble to see it.
I had sent the link to Samyukta. So probably she can share it with each one of you. Samyukta, you're there?
Yes, Marian, I will again share the link with all our mentors and master
Perfect.
mentors.
Thank you. Yeah, thank you so
Okay.
much.
Okay. Thank you. Thank you very much.
Yeah.
I will maybe just
Yeah, I think we can start. Think we can go ahead and start. Over to you, Flavia.
Thank you. I'll maybe just take the opportunity before while people are still joining, and I will share my screen with you, and I will show you the YouTube channel. So this is the YouTube channel for this CSIR implementation research. We have the video. So in the phase 1 of the research, we have had 8 seminars that our dearest master mentors presented to the staff in the field. So we have all of them here, and they are basically all of them are accessible. And now we are using the same platform to add the mentor series webinars. So this here is the first one that I uploaded just after we had the previous webinar. And we will be uploading them every time we have a webinar. So in the end of the webinars, you can all access, but you can also keep accessing. And also the champions of the project, they will be able to see once they are selected. And it's also going to be part of their own training as a champion. So I will put this, this link on the chat, and it will be there. I sent an email previously, but maybe not all of you received. So we'll keep communicating with that, and we'll keep announcing once they are uploaded. Right. So now we have already most of people connected, I assume. Maybe we could start. Marian, what do you think?
Yes, Flavia, I think you can go ahead and start. So again, welcome to all of you who've joined, and thank you for coming on time. Many of you definitely joined ahead of time. And just to cut it short, I'll hand over to Flavia so that she can do the needful. Over to you, Flavia.
Thank you. Right. So welcome to this second webinar on respiratory support and safe oxygen use. I will put this on screen mode. So we'll be presenting, we have 1 hour and 15 minutes of a meeting. And we will go through some slides of the webinar. We're going to talk about the CPAP, in RDS, the recommendations for WHO, some practicalities. Again, this is not a webinar that's going to teach about RDS because you all know about it. You're all mentors and you could be teaching this. So we try to focus more on practical aspects that you might face in the field when doing mentorship, and some things that could help also to teach the staff in the field that could be helpful for you during your mentorship process. I'm trying to put this on a screen sharing and just having an issue with my screen. I'll stop sharing for a while. Just go back to it again. Okay, I think I will have to have my camera off because my internet is also not amazing today. So it will be easier to go through the animations. Yeah, now it's working. No worries, we're just about to start. Here we go. I would just ask everyone to keep your mics off through the whole presentation. As if you have questions or comments in the middle, just can pop them on the chat, and the chat's going to be supervised. And if you have any questions after during the discussion, it would be really good to have discussion very active. So please raise your hand, and everybody will have a time to speak and to discuss and to share your own experience. And we hope that this is going to be a very productive session. Okay. So we have 35 minutes of presentation, then we go through the CPAP job aid that you are going to use in the project. And then we have 30 minutes for discussion. So going back to history, history of oxygen in neonatology. So oxygen in neonatology started to be used in 1780 with experimentations in neonates. And by that time, we noticed that oxygen increased the survival. Right, I have some echo coming back from somewhere. I'll just mute everyone. Right, that's better. Then, well, if oxygen increased survival, so let's use oxygen. So oxygen started to be using and a lot. And actually in 1970s, at this time, oxygen was being used as systematic intragastric. So the babies had intragastric oxygen being used from birth, all babies, regardless of their condition. And then as a result, in the 90s, we have these ROP epidemics that happened. And well, everybody knows Stevie Wonder. That's one of the preterms that were victim of the ROP epidemics. And this is just something that we talk as if it was in the past, but it's not in the past. It's really in front of us. The ROP epidemics had a three-phasic evolution. First time it was in the 50s. Then we had up after the 60s with the advent of CPAP and a lot of oxygen use that continued. And we have now with more survival, with more initiatives, and to improve newborn survival, basically. There's still a lot of use of oxygen and overuse of oxygen, and we have a third epidemic of ROP. So there are estimates that in South Asia and in Sub-Saharan Africa, ROP prevalence among screened preterm infants could range between 20 and 40% of all of them. And this is basically probably an underestimation because not all the preterms that needed screening are screened. So what does oxygen do? Oxygen does oxidative stress, basically. Oxidative stress means peroxidation of lipids, oxidation of DNA and proteins, and this basically causes inflammation and direct tissue injury. Preterms, they have a very low amount of antioxidants, and antioxidants in their own system, basically, and they produce very low amounts. We produce a lot, and we can balance antioxidant and oxidants, but preterms, they live in this imbalance, basically. So they are more prone to oxidative stress, which will cause tissue damage, and this will also contribute to most of all these preterm complications and morbidity that we have, as PDA, kidney damage, IVH, PVL, hypoxia, eryptosis, NEC, BPD, and RDS that we're talking about today, ROP. And what's interesting is that pain also causes oxidative stress by itself, and newborns, they are also, pain is very much underestimated in newborns. So this is something that we'll be talking in another seminar, but it's important to have that in mind. So this is a very nice saying. We started using oxygen for neonatal resuscitation because this seemed to be a good idea. And now we use because we always have. And not only for resuscitation, but also many places we use oxygen as a normal routine act, just because they have, and because they want to keep the babies with high SATs, and they think that they are more stable that way. So in the 1960s, there was the Kennedy baby that I'm sure all of you heard about. A baby of JFK died in 1963. And basically, this sparkled medical race to save premise. This baby was 34 weeks and died of hyaline membrane disease. And I think this is interesting, not going through this timeline in detail, but it's very interesting that you see from in all less than 100 years, how research discovery was done through time concerning RDS. Is that there was not much around here, and after 1960s, after the death of the JFK baby, there was a lot of initiative, a lot of money that went in NIH, and basically there was a lot of research. HMD was demonstrated. It was much more understood. CPAP was it was developed for neonates, and it started to be used, and it showed that increased survival. And we have the advent of surfactants. So what's RDS? Today we call it RDS, respiratory distress syndrome. Some people still call hyaline membrane disease. Hyaline membrane disease is how it was described before, because there was so much inflammation in the lung that it created a hyaline membrane basically around the alveoli. Today we have a second disease with the advent of CPAP and surfactant, but basically it's the main pathology is on pathology on lung development and on lung production of surfactants. We have lungs that are immature. They have reduced surfactant production and very reduced clearance. So as we see, surfactant production starts around 25, 26 weeks, sometimes 24, so it depends on the baby. We know that there is already endogenous surfactants in very small amounts that's coming out at 20 weeks for other pathways. But the production of surfactant, as we know, starts around here, and it increases progressively as you term when you have enough surfactant, basically. Also the lung development, alveolar septation, and alveolar phase is completely in the term. So our babies are all here, most of them, and most of them are prone basically to have RDS. Basically, they have reduced surfactant production, but also very reduced clearance. So basically, if they are born with some surfactants unborn, that's because they have just produced them for a long time, slowly, and they consume very fast. There is a clearance that is very, very slow, so they will not replace it. So that's why sometimes you have a baby that's born fine and gets worse, basically. And that's basically the natural history of RDS. So these babies, they have very poor compliance. They cannot establish an FRC, so they have poor oxygenation and increased work of breathing. And the natural history of RDS is that it gets worse, basically, in the first 2 or 3 days of life. And then you have babies like this with an X-ray, so increased poor oxygenation, increased work of breathing, and you have these images in the X-ray with very low volumes, so lungs that are completely atelectatic, collapsed, and with an alveolar syndrome, basically, that basically need 2 things. And one of the things that will basically change the course of RDS was CPAP. So even for babies that have very bad lungs and that would have a terrible course and that would die, CPAP changed their course because it keeps basically the lungs open. It creates alveolar recruitment. And it not only distends the alveoli, it also distends the upper airway. These babies, they have also tendency to close the upper airway, so the CPAP keeps the whole airway open, upper and lower. And by that, it will increase oxygenation and work of breathing. In preterms, it's even more interesting because CPAP will help conserving the small amounts of surfactant that these babies have. It also reduces alveolar fluid. We know because these babies, they not only have RDS, they still have some fluid in the lungs. They are all born with the lungs filled with fluid. And CPAP will also help reducing this alveolar fluid and will synchronize respiratory and thoracoabdominal movements, and they enhance the Herring-Brewer inflation reflex following airway occlusion. So they also help the baby regulating inspiration and expiration. These babies, they tend to have a very short inspiratory time and basically helps them having the right inspiratory time and avoid also airway occlusion and overinflation. Oxygen doesn't do any of this. So pure oxygen will not recruit the baby. Poor oxygen will basically create more free radicals and just tend to worsen inflammation, as you saw, by creating free radicals of oxygen. So this is just a visual. We can see 2 different images here. On this one, we have, these are rabbits, baby preterm rabbits that are ventilated. This one is ventilated with a PEEP of 0. And you can see the air becomes white in the image. So you can see when this preterm is breathing. And in inspiration, you can see the air entry. And on expiration, you can see completely collapsed. So this is the thing about not establishing FRC, functional residual capacity. So this one here has a PEEP that goes from 0 to 5. And basically what you see is that even on expiration, we still have air in the lungs. So the lungs, the alveoli is still open. So this baby has a functional residual capacity. And this is what CPAP is doing. And this is what CPAP helps the preterm doing. Something that a full-term baby would do normally. They would basically keep the lung open, keep a functional residual capacity. A preterm would not be able to do because of the lack of surfactant. CPAP comes and help them do that. So what's the WHO recommendation when to start CPAP? So we have recommendations for preterms, and the first recommendation is to start CPAP in preterm infants with clinical signs of respiratory distress syndrome. We know that CPAP will reduce mortality by about 50% in preterms by hospital discharge and also reduces morbidity. So CPAP decreases the use of mechanical ventilation by hospital discharge by about 30%. Second recommendation is CPAP may be considered immediately after birth for very preterm infants, less than 32 weeks of gestation, with or without respiratory distress. So this is based on two comparisons. First one is CPAP immediately after birth for very preterm infants versus supplemental oxygen. So we saw that these babies, they decreased failed treatment. They also decreased the BPD and decreased pneumothorax, and there is no evidence of harms with little or no effect in mortality and IVH, and there is no evidence of critical outcomes. So it seems to be positive. Also, CPAP immediately after birth for very preterm infants versus mechanical ventilation, that it's definitely the best choice. In the past, we were intubating all the preterm babies straight away in the delivery room without asking questions. So that's how these trials, they were done. And compared with CPAP, so CPAP decreased the failed treatment. They decreased BPD. There is no evidence of harm, and they might change mortality and also pneumothorax and IVH, and might have an impact in the neurodevelopment. So definitely the best way to go at less than 30 weeks of gestation, straight away, immediately after birth, would be CPAP, and whenever we can, it would be good to start CPAP for these babies. So what would be normal and abnormal breathing? So for breathing, we count respiratory rates. As you know, respiratory rate more than 60, tachypnea. We just have to remember everyone that when we are teaching them that they have to count in 1 minute. Sometimes the staff, they forget. And signs of respiratory distress, it's nasal flaring, as you can see, the first baby, intercostal retractions, as you can see here, severe chest indrawing, xiphoid retractions, and grunting, as you can hear. And this is the baby that's grunting. That's a severe sign of a respiratory distress, and also seesaw breathing. So to look into the kind of respiratory distress, it can be very challenging to teach staff that are not used to neonates how to identify a neonatal respiratory distress. And this is going to be fundamental, basically, when you are teaching them and implementing CPAP in these core facilities. A good option is to follow scores. You don't have to. It's not an obligation, and we are not recommending one over the other. Some sites, they will prefer Downs score, sometimes they prefer Silverman score. But we know that scores, they have a very good inter-operator reliability. And so it's very easy for the staff to just look at the score, classify, they don't forget, and they can, it might help them also how to report and how to transmit to the other staff when they're handing over, for example. So this can be very useful when you are teaching basically to the staff. So which machine to use? So that's the third recommendation. For preterm infants who need continuous positive airway pressure, CPAP therapy, bubble CPAP may be considered rather than other pressure sources, for example, ventilation CPAP. So there are different kinds of bubble CPAP. They are usually cheaper, they are usually more accessible than other sources like ventilator or infant flow. And most of our projects, our core facilities, they will have these ones. They will have bubble CPAP. Indigenous CPAP, we will be discouraging from all the sites, and we will be asking not to use basically indigenous CPAP. Right. So for bubble CPAP, there is a Cochrane review that came out of the recommendations, so it's found in here. So bubble CPAP may decline the rate of treatment failure, of CPAP treatment failure, basically over mechanical ventilator or infant flow driver of about 30%, 25%. But it probably doesn't affect mortality prior to discharge, doesn't affect the risk of pneumothorax. It might increase the risk of moderate of severe nasal injury. It increased in these trials with a number needed to harm of 14. So this is something that really needs to be addressed, and we need to pay attention when you are going through that. And the pressure source may not affect the risk of bronchopulmonary dysplasia. So that's why this recommendation is bubble CPAP is very good. But of course, if you in the sites that you are working or in the sites that you will be mentoring, they have other kinds of CPAP like the ventilator CPAP or infront flow driver. Its driver is completely okay that they still use them. So these are the machines that we will be finding in most of the places. So this is the Vayu CPAP, this is the Pigeon, this is the America, and this is the Fission vehicle. Bobo CPAP is also interesting because it keeps a PEEP that has more an oscillatory curve. And the effect of the bubbles could have a high frequency effect in the airway. And this could help basically gas exchange. So it could be also more interesting because of that. And it could be one of the reasons why it could reduce the treatment failure. So why not indigenous CPAP? Indigenous CPAP, what we are calling indigenous CPAP here is CPAP
Flavia?
without humidifier. Yes.
Can I put the poll there? Do you want them to answer? Can you see it?
Oh, yes. Thank you. I
Yes.
cannot see the poll.
You can't see it? It's there in the chat.
So there
What
is a
type
poll
of
in the chat. I can see it in my screen. Yeah, you can go ahead, Mariam, please. Yeah.
Yeah, I've put a poll, a question in the poll. What type of CPAP machine do you use? And I would request if you can respond to that, as many of you, bubble CPAP, indigenous CPAP, and others. Yeah, I've got 3 responses, which are saying bubble CPAP so far. Anyone? 3 responses. Any more responses? Can you all see the chat? If you all can respond, it'll be great. 6 responses, 8 responses. Okay, all of them are, we have 8 responses and all are saying.
Please give some response.
Yeah, and we also do have others also saying bubble CPAP on the chat. So most of them are saying definitely bubble CPAPs, Flavia. Over.
Right. So that's good. So most of you are used already to bubble CPAP, and this is what most of the core facilities will also be using. So this is very good. What we are calling indigenous CPAP here is CPAP without humidifier and without blended gases. Why that? Why we are saying no to indigenous CPAP? Because without humidity, the secretions may become thickened and there can be pooling of mucus. This increases the resistance to the airflow and also increases the work of breathing. And it can complete block the airway. You can also have impairment without humidifier of the ciliary, basically this impairment of the ciliary clearance. You can be more prone to infection. And you can also have a spasm and baby can increase basically the work of breathing because of that. So heated humidifier is superior to humidifier, but definitely we need to have any humidifier. So blended gases, that's again, we already spoke about it. FiO2 must be titrated to avoid hyperoxia. So we definitely don't recommend to use CPAP or any kind of respiratory support without blended gases. So that's why we'll be talking a lot about indigenous CPAP, and it's part of the assessments that will be done. So it will also be part of the work we will find in the facilities. So concerning blended oxygen, this is just quickly a graph. We have different kinds of CPAPs, different kind of blended oxygen, so different prices also for them. So basically, these ones are here are the no blending. That's the indigenous CPAP that we are saying no to the use of those. We have CPAP machines that blend from 30 to 100%. So this was published in 2022 when it was not available. Now it is. So one of the examples is the Vayu CPAP. So this is a very low cost CPAP machine that has a blender. It's this red thing inside. And that will basically connected to an oxygen tank or concentrator. So you need an oxygen tank or concentrator, and can blend from 30 to 100%. If you want to keep 21%, you would take this off and you connect it straight away to a source of 21%. So it needs an external source of air or oxygen. The Diamedica, that's the one that we used in phase 1 and that we chose as first choice. Why did we do that? It's a little bit more expensive, but it's a medium cost CPAP. It has a standalone air compressor and a concentrator. So basically, it doesn't need any gas supply source, and but needs electricity. And it also has a humidifier that is integrated here. So the vial also has an humidifier, but it's not heated. This one has a humidifier that is heated. And then we have blending with high pressure. That's basically wall source, like inline oxygen or air. So these ones you can blend from 21 to 100%. So generally, these ones are limited to tertiary facility. You need more infrastructure to use these machines. You have high precision blender, these ones that is needed. They are more costly. For example, this is an SLE, a ventilator, like all kinds of ventilators. And also, this is a Fisher & Paykel CPAP that you can use with a bottle, but you will always need this kind of blender with it. It doesn't come with a blender on it. And then you have the Pigeon. Basically, it's between both of them. The Pigeon has a compressor. It's this part here below for air, but it still needs oxygen. But it does have an integrated blender that will blend between 21 and 100%. And needs electricity. So the only one that doesn't need electricity is this one, is the Vaio. And the Pigeon will need electricity, the Diamedica will need electricity. And well, they can be used with an external power source. So we have a little bit more details on that. I'll not go too much in the details. You will have that after. And you can go through it, but this is again concerning the blending. We already talked about it. Concerning the humidification, if it's heated or not. Now the America is heated, and Pigeon and Fisher & Paykel are heated. Only one that's not heated would be this one, the Vaio. The tubing is a little bit different between them. These ones, they have low resistance components. But the Vaio is the only one that doesn't need electricity, which is really interesting. And they had different consumables. Each CPAP would have a different consumable. So in basics, each CPAP will have to be adapted to its own environment, to what you have in your own environment, and what can be provided, and what's the infrastructure that you have. But what's important here is to realize that when you go to the facilities, it's important to look what kind of CPAP they have, but also if they have the infrastructure to use that. Machines that need electricity will need electric supply. And for example, in phase 1, in places like in Nigeria, they started to they had initiatives like having solar energy to overcome this challenge. Some other facilities might have to need to find a solution for compressors because they don't have compressed air, and this happened in also other facilities. So this is something that needs to be taught and needs to be seen from the beginning. If it's not there, we should do the best and start to advocate and start to work so it's there. So we are in a phase right now. We are looking into the material. We are trying to make sure that everything is rare and it's ready. So we will not face the same issues that we faced before. Okay. I have to take my camera off again. Right. Let's pass through slides. So this is just a reminder. Some facilities might still use ventilators and intubate babies. Some of them might use high flow, and some of them will be using CPAP. regardless which kind of ventilation that we are using, we always recommend only use with blended oxygen. So this is a must. This is extremely necessary. And we are recommending not to use a low flow cannula, head box, or free flowing preterms with RDS. So this is a no. So we can definitely use oxygen. Babies might need oxygen on CPAP or intubated or on high flow. But if a baby needs oxygen, a preterm baby needs oxygen, we will need to start respiratory support and titrate oxygen with a blender. So that's a very important message. And always with a saturometer. So it's now we go through the interfaces. So for CPAP, we have different kind of interfaces. So we have basically two groups. We have these kind of setups where we have the tubing come on the sides, and we use hoods on prongs. There are different kind of prongs that we call hoods on prongs. Some of them are more rigid, some of them are less rigid, but basically they have the connectors on the side. They might have this cap that we can open to here the lungs, for example, and close to avoid basically cell air leak. And they need to be well fixed in the nose. We'll see a little bit about that later. And then we have these ones that are different kind of prongs that can be used on different kind of setup. That's also known as a snorkel, because it looks like a snorkel. And in most of them, you can alternate from masks to prongs, which is very interesting also. And you have different, but most of them are proprietary, so they belong to the machine that you're using with. And but many of them you can use in different kinds of machines too. So mask or prongs, very good question. Many sites will prefer prongs, many sites will prefer masks. Definitely prongs seem to be easier to use, especially hoods-on prongs. There are meta-analyses that have been published that suggest that using masks rather than prongs for CPAP may reduce treatment failure by about 30% and moderate to severe nasal injury, but they don't affect mortality or BPD or the risk of pneumothorax. So the most important outcomes, probably they will not change. And so this is to decide. But rotation of masks and prongs seems to be very interesting. This is a systematic review that was published in 2024 of periodic rotation versus binasal prongs. And we saw that periodic rotation reduced the risk of nasal injury by 40%. And there was no difference in CPAP failure. There was also another RCT that was published more recently that was not included in this meta-analysis of patients with less than 35 weeks. They were doing 8-hourly rotation of masks versus prongs. And they also saw that may reduce the risk of nasal injury when compared with either interface alone, so either mask, either prongs alone. So rotation is very interesting because it changes the point of contact in the nose and just basically gives a break to gives a pause on the pressure points. So whenever can be done, it's good to be done. Sometimes it cannot be done because there is only prongs, and then we'll just have to be very attentive. So how to set it up?
To put the, sorry, Flavia,
Oh,
do you want me
yes.
to put the poll? Yeah.
Please.
Yeah, I've put the next poll. You can see it on the chat or in the screen. What type of interface do you usually use? Nasal prongs, nasal mask, or any other? And if you please respond, thank you. Nasal mask, there's one response. Nasal prongs, 2 nasal mask, okay. Thank you so much for your response. Mostly nasal prongs, Flavia, and some of them are also saying alternating with the nasal mask, or some say both. Yeah, great. Thank you so much for your responses.
Great, thank you so much. So again, you are used to all of that, so that's very good. So for this setup, I'm sure you always know that you have different sizes of caps. They just need to be the right size to the head of the baby, adjust to the head size. You have usually in most kits for prongs and masks, you have a measure tape that you can use to measure what's the right for the baby. But what's very important is to measure masks according to the nose size and avoid the eyes. And the prongs are supposed to fit snugly in the nostril. So this is very, very important. So we can have the delivered pressure that we want without pressing the septum. So we avoid septum lesion. And for safety, what's recommended is to have 2 millimeters from touching the columella, so the septum there, to avoid pressure. Also important is that avoid kicking in the secret and the water in the secret, so it can be a little bit up. So the water will not come up, basically it will only go down, especially when humidifying heated, you can have some condensation in the secret. So how do you monitor respiratory wise a baby for a doctor point of view? So work of breathing is the first thing. So we have to follow up how is the work of breathing, how is the oxygenation, and how is the ventilation. So for the work of breathing, signs of respiratory distress that we have been through, for the oxygenation, saturometer, and then again, we recommend saturometer continuously for these babies whenever possible, and following the limits for preterm. Adjust PEEP that will interfere in oxygenation if needed, titrate oxygen, and having this target between 91 and 95%, that's the recommended target for preterm. Remembering that for resuscitation, we always have preductal SATs, and then the SATs can be attenuated in the knee, especially if the baby is stable. The site, I mean the hand and feet. Ventilation is basically CO2. Blood gas or transcutaneous CO2 whenever available. Probably it will not be available in most of the core facilities. Regardless, every baby needs to have vital signs written off hourly. Saturation monitoring is recommended continuously. So then we enter in the nursing care. So most of CPAP is nursing care. Nurses are vital for CPAP success. And specific to CPAP, apart from vital signs, nurses, they must make sure that the patient keep free of secretions, that the mouth is suctioned and the nose is suctioned when needed, that we have optimal humidity, that the nasal prongs are removed every 3 to 6 hours. We check the nose if there is need for cleaning, if there is need for cleaning or suction, if the prongs need to be cleaned or replaced. Also do hat releases with feeds of care to reduce to release dispersion in the ears. Ensure good position and reposition the baby every 6 hours. This is for the airway, to keep a good airway opening, but also good positioning will reduce work of breathing, especially if it's prone. And position according, it's very important for development also. So with cushions, with we can also support the baby with the position, and asymmetric position is also good, but always remember to keep the head in the same line as the body. Equipment function and monitoring. So CPAP and gas sources need to be working, so this needs to be checked at least every shift and anticipated if there is a need for replacement. Machine alarms are working, so the machines that have an alarm, they also need to check that the alarms are working and set. Continuous pulse oximeter with the SATS alarm activated with the right target for preterms. CPAP and humidifier settings checked frequently and changes documented otherwise. Hourly obs for vitals, temperature stability and comfort. But it's just on comfort. We can do lots of things with babies on CPAPs. This is a non-nutritive suckling. See babies super comfortable on CPAP and receiving a little bit of breastfeed of express breast milk. So this can be done before cares. It's very soothing and helps them how to regulate. KMC. So we can do CPAP on KMC, and it's basically going to be the same process, and it's going to be the same targets, the same monitoring, and the babies will probably, the babies definitely be also more regulated. They will be less stressed, and they might be have a much better evolution than if they are not on CPAP, they are not on KMC. So whenever KMC is available, which should be always, let's advocate in the facilities for CPAP on KMC. So how to prevent? Well, of course, you have complications where I spoke about nasal injury. So how to prevent nasal injury? Ensure that prong size is adequate. Ensure the gap between the prongs and the septum. Evaluate prongs positioning and skin integrity. Ideally, every hour, they should have a look when they're taking vital signs. Look at the nose, look at the position of the prongs, see if everything's okay, if there is no visible breaking of the skin, not necessarily taking it off. Whenever possible, rotate masks. Better treatment basically is prevention. Some sites might use a protection in the nose, like Confeel or Tegaderm. So this will depend on local protocol, basically. Ear and scalp injury. So we can have pressure necrosis around the head and the ears, head molding, due to failure to release hat and strap regularly. So check the head size, release the head, and evaluate ear positioning. So this would be ideally, they can be do before feeds, head releases, or at least during cares. And it's highly preventable and less common. CPAP belly, very common. Basically, severe abdominal distension that can be so important that you have respiratory restriction. And it can also cause delayed gastric emptying, and it can cause that you have digestive issues, more increased residues, or more, or even spits or vomits. So sometimes it can be confused with NET, which is the case of this baby, but it's basically ended up to be just too much air in the stomach. So the best way to work with it, the best workaround, is to prevent. So prevent by having always orogastric tube or a nasal gastric tube, stomach decompression regularly, and tube kept open as possible. Pneumothorax, well, pneumothorax is likely to happen in severe RDS for increased negative pressures, basically increased work of breathing that the baby will have in very, very low compliant lungs. Or it can also happen when the baby is getting better. And this is very important for monitoring, because when RDS is improving, basically the compliance is improving, and the babies don't need too much pressure. If we don't change that, the pressures keep high and they're not adapted to the lung of the baby, they can cause hyperdistension and pneumothorax. So that's very important to monitor continuously and adapt CPAP baby's condition. So this is just to remember also probably to some sites, they will not, most of the core facilities, they will not have X-ray in the facility, but they can still do transillumination, and in preterm, it's very, very useful to diagnose pneumothorax. So troubleshooting, basically, right material, no leaks and no water, and right settings. CPAP's not working, check if prongs and masks are fitted properly, that adapted in size and sequence, adapted to the machine. There is no leaks, no water. The position in the nose is correct. There is no leak or excessive water in the circuit. And the right settings, that you have the appropriate PIP and the appropriate FIU tube. Also something important for bubble CPAP, that you have bubbles present and the water level is correct. As you see in this image here, when you fill the water, it has to overflow a little bit. This is for the efficient and bacon. For the other machines, might be different, but always make sure that the level is correct, so you have the right pressure delivered. So when to win, we're going through that with the job aid. But basically, baby does not need oxygen and baby has no respiratory distress sign. We can start to win. First FiO2 and then PEEP one by one until 4, 5. 5, it would be ideal to start thinking about weaning. And if it's okay, if baby does not tolerate, baby becomes multi-keeping or increased work of breathing, you can always put the CPAP back, but it has to be under monitoring. So now we're going to have to see the job aid. Let's just stop sharing quickly. Here we go. Right, so this is our CPAP job aid. We used it on phase 1 already. My screen is blocked.
We can see it.
You can see it, yeah, but I cannot move it. So I will just have to wait and I hope that it will be.
Yeah.
Yeah, it's back.
Yeah.
Very slow.
Mhm.
Right. So we have a few pages in the CPAP job aid. So it's a guide on how to start CPAP and how to go through a CPAP usage. So starting with CPAP indication, who? So all babies less than 32 weeks or less than 1 kilo always. So this is what we call early CPAP. All preterms less than 37 weeks or less than 2 kilos with any respiratory distress or SATs less than 91%. So respiratory distress or desaturation in room air. And babies with less than 37 weeks of respiratory distress also are entitled to CPAP, even if we are on a research that's focused on preterms. So we have signs of respiratory distress here. So this is for the staff. If they have questions, they can always have a look and see what's respiratory distress. So we start with step 1, which is for babies less than 32 weeks or when we are weaning. So this is the first case here. So babies that are looking well, and we start CPAP with a PEEP of 5, with a FiO2 of 21%, with a flow from 6 to 8 liters. We always start with the lowest flow to have bubbles, basically. And we follow the baby. Start the baby, stay on the bedside, see how the baby tolerates, and then we follow for 4 to 6 hours. If the baby goes well, there is no respiratory distress, the SATs are more than 90, so on the target. We can start pausing the CPAP. So when you do the pause CPAP, the nurse, at least the nurse should be there and she should be on the bedside, or the doctor, so the healthcare provider should be on the bedside, see how the baby tolerates. We observe for 30 minutes with monitoring. The baby is stable, we can wean the CPAP. Of course, if respiratory distress signs appear at any time at that point or even after, we put the baby back on CPAP. Or also if the SATs they go below 91%. And if the baby is still on respiratory distress or the SATs below 91%, either on this case, we continue the algorithm on the case 2. So here we have the target SATs and some observations. I'm blocked now. Just see if it comes. Yeah, only goes down. It doesn't. I will just have to close this again. I apologize. It's blocking my computer. Maybe if you have them, Marion, I would be very glad if you can
I'll
share.
just open it. Sorry.
Thank you.
Maybe you continue while I just access it.
I will continue. I will just continue. Yeah, good point. And then we can go for the job aid just in the end. Okay. So we have had some learnings from phase 1. Basically, there were some barriers identified for the use of CPAP and some strategies that were taken to overcome, and that we're just sharing because it might happen on phase 2 too. So lack of training on CPAP, definitely widespread. This was tackled with trainers that were, we had this trainer pool, which were the master mentors, which are you, and training on CPAP formal and on-site. So a lot of training that was done in the facilities. Infrastructure and lack of equipment. So some SNCUs, Carnos that had issues with medical gas, CPAP and pulse oximeter shortages. So this was the strategy that overcame these problems with equipment. Doctors, so many facilities did not have doctor, and this might happen again. So this was very important, especially in Bangladesh. An amazing strategy to empower nurses with nurse-led CPAP. Again, a lot of CPAP's nursing work. So it would be great if from the beginning of mentorship, nurses can be empowered and they can be involved on that, because it's a lot of nursing care. Confidence of the provider. This was we overcame with mentoring, with coaching, hand-holding, data-driven process monitoring, a lot of meetings, audit feedback, and WhatsApp groups, basically direct communication between mentors and staff. And motivation of the providers, also appreciating, encouraging WhatsApp groups. This helped them a lot. And we did a survey with the mentees, and this was very interesting. We asked them, what were the main difficulties you personally experienced when trying to apply CPAP in your clinical work? And basically, most of them, they said it was either lack of equipment or supplies, and which was something that was difficult to tackle, and that we are trying to prepare well now. But many of them also said lack of hands-on training and supervision, and limited support from other staff and management. So these two things are basically direct link to mentorship, and these are things that would be good to have in mind when you are going on CPAP. The staff really appreciate, and they really need this hands-on supervision and support, basically, from the management. You can be advocate through mentorship too. What they appreciated. So they appreciated almost everything. So it was very much appreciated. They appreciated a lot step-by-step demonstrations by the mentors. So when you are there, it would be amazing if you can demonstrate how to do, if you can help them practice with guidance. So they also appreciated a lot that. They appreciated the job aids that we are going to go through just in a minute, and regular check-ins for follow-up and discussion, and encouragement and problem-solving support. So basically, all the strategies that were used on mentorship were very much appreciated by the staff, and they still would love to have more hands-on. So this is something to keep in mind for when you are going there and giving the mentorship and implementing CPAP. So now we can go to the job aid. Is it?
Yeah.
You have
Can
it?
you see it?
Yeah, great. I will stop sharing.
Can you see the screen?
Not yet.
Yes,
I think
we
it's
are seeing.
coming.
Yes, yes.
We can see, we
Yeah.
can see.
Perfect.
Yes.
So the first part Flavia has already described. Step one, Flavia, you finished that?
Yeah.
Yeah.
So step
Can
one.
you see? Yeah.
Yeah.
Okay.
So step two. Oh, we can go to step two. And we move a little bit down to step two.
Yeah. Yes.
Yeah. Thank you. So step two, less than 37 weeks or less than 2 kilos. So these are babies, all preterm babies, basically, and small babies with respiratory distress, or saturation more than 90%. So the baby that you have typically in front of you that has increased overbreathing, has respiratory distress, but doesn't desat. Saturations are fine. So for these babies, you start with a PEEP of 5 to 6, and with an FiO2 of 21%, and assess for clinical improvement within maximum 15 minutes. So basically look how the baby is doing and keep assessing. If there is no respiratory distress and the SATs are more than 90 steadily for 4 hours, you can start pause CPAP and go back to item 1, which is like a stepping down. If our respiratory distress persists, we run troubleshoot. So what's troubleshoot? So troubleshoot, we have the DOPE that most of you know, and it can be helpful for this step to know these acronyms. With D, we have for prong displacement, so very, very common, especially for Hodgson prongs, that the prongs, they kink, especially those ones that are very, very soft, they kink a lot. They can block, and this must be followed, especially if the circuit is heavy and pushing against the nose, against the face. So this is the first one that needs to be checked. Then obstruction. So water in the circuit, water in the prongs. Oh, we lost it.
Sorry,
lost
one
it.
second. Sorry. I can't do both. Yeah. Now, can
That's
you
good.
see?
Thank you. Yeah. Water in the circuit, water in the prongs, secretions in the nose. So that's again part of the nursing care to reduce secretions, to check for secretions. But this is something that can happen even if we're checking very often. P from pneumothorax, also pain, and we also have CPAP belly there. So also can make the baby get worse, basically. And equipment failure. So it can be the machine that's not working well, and it can be a problem with electricity. It can be a problem with the circuit that's not working well. Just remember that for babies with bubble CPAP, we need to have bubbles present all the time, and this is also part of the assessments that we ask the SSNC leads to do. If there are no bubbles and no leaks, we can increase the flow. This to make basically until we have bubbles appearing. Also, always remember the level of the water must be on the water level that's recommended according to the manufacturer. So if run troubleshoot is run and there is no issues with the DOPE, we increase the PEEP up to 7 and 8, and then we go back up again. Third case, if the baby is not getting better, or in the cases that you have respiratory distress and or SATs less than 91. So we have the baby that has increased local breathing and is desaturating. So again, we start with a PEEP between 5 and 6 and some oxygen. So a FiO2 of 30% to start, and then you titrate basically progressively the FiO2 as the baby needs. So if the baby is getting better, there is no respiratory distress, and SATs are more than 90 for 4 hours, you decrease the FiO2 progressively until 21, and you go back to 1 for weaning. Other possibilities is that the respiratory distress persists. So if respiratory distress, so increased local breathing is still there, but the SATs are tackled, run troubleshoot, and if everything's okay, we can increase the PEEP up to 7, 8 progressively. So if you start to 5, increase to 6, to 7, and the maximum to 8. If the respiratory distress is better, but the baby has still desaturations, so we are going to increase the FiO2 progressively, basically, and assess the baby continuously. This baby must be monitored, and these are the most critical ones that need. These ones need definitely the saturometer to be on them continuously. Right, so we can go down a little bit. So for weaning, what's the weaning criteria? So when the respiratory rate is less than 60, when the saturations are greater than 90, when there is no increase in the work of breathing, no increase in the work of breathing, and no increased work of breathing, and there is no sign of respiratory distress. So what is CPAP failure? So basically not all patients will improve significantly with CPAP. When PEEP 7 to 8 and troubleshooting is done, the patient might still have respiratory distress. So some people, some sites, they would stop CPAP because they think the CPAP is not working. So we just need to remember them not to stop CPAP if there is no other advanced support. If you cannot intubate the baby or give surfactant, they would just have to keep the CPAP, ensure that the baby is comfortable and the other systems are stable, and weight on the baby. Lying on the belly, as I said, positioning can be done if the baby is monitored continuously. And agitation is not failure. Always check for pain and ensure that patient comfort as pain increases respiratory distress. So we have do's and don'ts that follow. Insert orogastric tube when using CPAP and open after 1 hour of feeding and check for air regularly. Change CPAP tubes every week and prongs every 3 days if soiled. Change humidifier water every 12 hours. So these 12 hours are recommendations from Diamedica. You might have different recommendations for all the different CPAPs. Definitely follow them. During stabilization, weaning, and after any parameter changes, always use continuous oximetry. Check the nose integrity every 3 hours. Keep the baby stable, blood glucose stable, temperature stable. Don't use normal saline in the water bottle. Don't use tap or on-board water because of the risk of infection. Don't start on CPAP without washing hands. Don't wean CPAP if the baby still needs any support. Always wean FiO2 first. Don't place the prongs too tight or touching the nasal septum because of risk of injury and necrosis. Remember them for the 0.2 millimeters. Don't forget about patient comfort and pharmacological measures, for example, KMC. And then we have maintenance after that, so which is a chapter that is specifically for Diamedica. So facilities that have different machines will have different maintenance, but it's very, very important to ensure that there will be a maintenance protocol for the machine that they are using. So we have prepared this one for Diamedica. It's part of the job aid. But when you'll be there in the field, in the core facilities, you just have to ensure that regardless the CPAP that they have a maintenance protocol, that they have a cleaning protocol after use, that they have a cleaning protocol for reusable materials when they have reusable prongs, reusable circuits, and cleaning for the machine, and also maintenance for the machine. So this will be circulated. We'll be able to go through that after this presentation. So now we are past our time almost for the training. We still have time for the discussion. I know that there are some questions in the chat, so I think we can go through them right now.
As a respiratory support, in addition to CPAP, how do you recommend surfactant for RDS?
Yes. Well, whenever you, yes, we are not discussing surfactant in this presentation because it's targeted for district hospitals that most of them will not have surfactant, which is also, it's consumable, that is very expensive, and it's another history. So that's why we are working on the CPAP because it's something that they will have it, they will keep it, and it will also change the target. Surfactant without CPAP will not, there are no trials of surfactant without respiratory support, right? So respiratory support comes first. Now, if the facilities have surfactant, definitely we were not going to say not to use surfactant, but all these district facilities, unfortunately, they will not have most of them. So whenever we don't have surfactant, we will have just to go ahead and follow the respiratory support with CPAP. And as I said, if they have other kinds of more advanced support, it's fine if they use them.
There's another question by...
If I can come in, Flavia,
Yeah.
on this?
Yes, Suman.
If you have surfactant, and I think what most of us do when we have access, is for a baby who is on CPAP, if the FiO2 is more than 0.3, that is 30%, we consider that the baby is eligible for surfactant. Yes, you need to give good CPAP and don't hesitate to go to pressures of 6 or even 7 when you're giving, provided you're monitoring well. This is only if you have surfactant, then you will consider at 0.3. I think that was the answer. Maybe if you're lucky to have it, yes, you can go ahead and use it. I hope that answers